Am. I'm Mrs. J for Absolute Medical Coding Institute, or AMCI. I'd like to explain these spine procedures by doing a reenactment. So come on, work with me on this one. All right, we've got a patient who is complaining of neck pain that radiates down to her arm. She was referred to the neurosurgeon. So she goes to see the neurosurgeon. The surgeon views the films and determines that the patient has some things going on with the spinal cord. See this yellow image? That's the spinal cord. And if you can see right below the right below the word spinal cord, you'll see the disc. The disc right here, the inflamed disc, is located between C5 and C6 vertebrae. And that disc is actually bulging out and touching the spinal cord. And that is what's causing the patient the pain to radiate down to the arm. So the doctor also determines that the patient has bone spurs, and these bone spurs are right up underneath the herniation. And another name for bone spurs is osteophyte. So the neurosurgeon diagnoses the patient with cervical disc herniation. We know it's cervical because it's a part of the cervical spine, and the patient is diagnosed with the herniation between C5 and C6. The complete diagnosis is cervical disc herniation with osteophytes at the C5 and C6 levels. The patient is recommended for surgery, and the doctor schedules a cervical discectomy and osteophytectomy. All right, and it will be performed on the disc between C5 and C6 vertebra. On the day of surgery, after being prepped and draped in sterile fashion, the patient was placed in supine position. And from anterior approach, this means the incision was made from the front. Another indicator that this is an anterior approach, the patient was lying in supine position. Now, the approach is where the doctor approaches the procedure. After the incision is made, retractors were placed to hold the skin back so that the physician can properly visualize the surgical site. Now it's time for the definitive procedures to be carried out, and those procedures are discectomy and osteophytectomy, and pretty much removal of the disc and the osteophytes. Now the disc was removed with a wronger. That's the surgical instrument that you see here. That's a wronger, and they just pretty much pulled the disc from between C5 and C6. After the disc was removed, the doctor used a burr drill to remove the osteophyte. Now we've got a hollow space, and the doctor has to fill that hollow space with an implant called a graft. But first, the doctor has to obtain the graft, and this is called harvesting. The neurosurgeon harvests the bone from the iliac crest, and it's right here. That's your iliac crest. This big hip, part of the hip, got a lot of good bone there, and it is a common source of graft harvest material. Now, if you want to see what it actually looks like, you'll see it on the right. That's how they harvest the graft. from the iliac crest. Next, the patient's blood is drawn. Then they take the bone from the iliac crest and the blood, place it in the grinder, mix it up for just the right consistency. The graft is ready for implantation when it looks like this. The next procedure is implantation of the graft. The doctor takes the graft and places it right between C5, C6 in that hollow space, right in there. And this process is called fusion or arthrodesis. Now the doctor's got to make sure that the graft remains in place and secure. And this next procedure is called instrumentation. The instrumentation is applied to secure the graft in place. Now the instrumentation that you see is a non-segmental instrumentation. Okay, there is only one piece to this instrumentation. That's why it's not segmental. So this is a non-segmental instrumentation. Okay, so the procedure is done. The surgeon removes all of the surgical instruments, then sews the patient up very carefully. The patient goes home for 6 weeks, then returns to see the neurosurgeon for a follow-up visit. The neurosurgeon views the films and the patient's surgical site and gives the patient a clean bill of health, then releases the patient from care. The end. No, not really. All right, so now we're going to use this patient's surgery to summarize the procedures. And this summary actually represents how to code spine procedures. All of these procedures are not always performed in all spine surgeries because my reenactment is not actually true because I did not have a harvest in autogenous harvest. It didn't come from me. But all of these procedures are components of a spine surgery procedure, and you will need to code them. Remember, we are only going to code what the doctor does. So you need to know all of the procedures that the doctor could potentially do. First things first. Which position was the patient? What approach did the doctor take? You have to code the approach. Is it anterior? Is it posterior? Is it lateral? Whatever it is, you're going to code according to the approach. Next, your definitive procedures will be carried out. In our case, we had a discectomy and an osteophytectomy. You only need one code because the osteophytectomy is a bundled procedure. Next, we code the harvesting of the bone graft implant. Next, we coded the fusion or the arthrodesis. And finally, we coded for the instrumentation, the spinal instrumentation. The key to successful spine coding is forensic reading. Understanding what procedures are being performed and only coding for those procedures. That's it. Now, there are a lot of parenthetical guidelines that you'll need to read. However, if you follow your FTRs, I think I addressed most of the guidelines, if not all of the pertinent guidelines, and you can find them all in your TTT manuals. And through thorough practice and continual practice, I am confident you will become spine surgery pros. I know it. So I encourage you to follow along in your TTT manuals as I may be clarifying some guidelines and definitions. All right, let's begin with the FTRs for spine procedures. The first is approach. Know the approach, the way the doctor approached the procedure. You can tell by the way the patient is lying. If they are lying supine, then the approach is anterior. If the patient is lying prone, then the approach is posterior. Posterior. Okay, so you get the picture. If the patient is lying on the side, why, that's lateral, and a lot of the codes are built upon selecting the correct approach code. Next, you'll need to know the number of discs and or segments that you're coding for. Number 3, you need to know if a definitive procedure is being carried out and which one. Number 4, if arthrodesis is performed with other definitive procedures, you're going to need to use modifier 51. Okay, you're going to have to append that modifier 51 to the arthrodesis procedure. Was instrumentation used? Was bone graft used? All right, so that's pretty straightforward. Now here are some general keywords because you're going to have tons of keywords. But arthrodesis, instrumentation, decompression, discectomy, osteotomy or osteophytectomy or osteophyte, any kind of bone removal, that is a keyword, and laminectomy. Now, there are some little quirks when it comes to spine procedures, but these quirks are often eliminated when you read your guidelines, and also read forensically. Watch the code instructions or the code language. In some of the procedures, you will see that it says code the first segment separately. So code the first one separately and then follow the instructions for the subsequent codes. And sometimes you're going to see those add-on codes too. And when you see those add-on codes, don't append modifier 51. And also instrumentation and bone grafts. These are add-on codes. Well, most of them are. And if it is an add-on code, do not use modifier 51. That's a general coding guideline that I pretty much think you've got that one nailed. I did say not all spine procedures are carried out in each procedure. So if you're having an operation, you're not going to have all of those procedures, not everyone. So I need to clarify some things. Now, for the definitive procedures, there are no more FTRs that I want to offer you, but I do want to give you some FYIs. Number 1, make sure that you append modifier 51 for subsequent definitive procedures. You know, you can only code one primary procedure, and then the additional procedures will need a 51 modifier. Another thing to pay attention to, many of these procedures involve co-surgeons. Yes, these spine procedures take very long amounts of time. The more complex the procedure, the longer it could be. My mother had a spine procedure last year, and that procedure took 12 hours. It was the longest procedure. She went into the OR at 7, she got out at 7 p.m. Now they give you, they put all the patients' names and their times, not necessarily their names, but there's a number. And I knew my mother's number, and my mother was the last patient. So when the doctor came out, he was a neurosurgeon. He said that was like brain surgery. So I digress, but he would not have been able to carry out that procedure if he was the only procedure. Who could stand there for hours? No. So co-surgeons do often carry out these definitive and spine procedures. Next, watch your parenthetical guidelines because they will guide you. They will keep you on task if you're not familiar with some of the protocols. Also watch bundled procedures. You're going to see that, as in our definitive situation, we had a discectomy, and with that discectomy, the osteophytectomy is bundled. So we're not going to code it. So watch your bundled procedures. It's very common. Now, also, if you didn't notice, we used a nervous system code for our definitive procedure. We did because it involved the spinal cord. Anytime you have a discectomy procedure, it's a spinal cord procedure, so that code could come from the nervous system. Also, any codes involving the decompression. Decompression is associated with the spinal cord, relieving the pressure of the spinal cord. Also, common definitive procedures are from the musculoskeletal section. So you're going to see bone incisions and excisions. The bone excisions are laminotomy, osteotomy, foraminotomy. Your excisions are laminectomy, corpectomy, and spinal cord decompression procedures. And you know, any kind of spinal cord or nervous system, you know, that's going to come from your nervous system. So, like I said, we're not going to change the FTRs. The approach, anytime you see a definitive procedure, you should put the FTR there. The approach, the definitive procedure, arthrodesis. When arthrodesis is performed, you need to append modifier 51, and is instrumentation performed, bone grafting performed, and you need to know the number of discs and segments, and just make sure that you're aware of these FYIs. Okay, so this is a look at my chun. If you look in the excision section, this is at code 22100. Just want to bring this to your attention. Some of the code language you'll see and why you need to pay attention. Partial excision of posterior vertebral component. Example, spinous process, lamina, or facet. For intrinsic bony lesion, single vertebral segment. So this is one segment, cervical. So just pay attention to the section of the spine, you know, where on the spine you're coding, and the number of segments, and also those parenthetical guidelines. It says for insertion of posterior spinous process distraction devices, and it tells you the codes that you need to see. Just read, and I promise you, reading is your friend when you're coding spinal surgeries. Okay, so when you have definitive procedures, just make sure you, place or notate your FTRs at the bottom of the page. They will help you. This is what you need to know when you're coding arthrodesis or fusion. FTR Code Series 22532 through 22819. You need to know the approach. Is instrumentation used? The number of spaces determine the number of levels. That's important. And use modifier 62 for co-surgeon. And just so you know, arthrodesis procedure is the process of immobilizing the joints. So you want to make the joints, you don't want them to be able to move, so you immobilize them. And you can use both grafting material and instrumentation. So or instrumentation in this process, and there are FTRs for both the grafting and instrumentation. But you will have to code for the surgical technique of performing the fusion or arthrodesis, and that is what this is. And these are coded according to levels, so you'll need to know where on the spine and the number of levels. We're not coding the hard part, we're coding the spaces. So the spaces determine the number of levels. Got it? All right. And here is a replica of my chun. And what really sticks out is the location on the spine. If you can nail that, you may be able to eliminate some incorrect answers off the bat. And that's it. Instrumentation also has FTRs on how to code it. So when you're coding for code series 22840 through 22859, and most of these procedures are add-on codes, not all of the procedures, but most. And you need to know when you're coding instrumentation for spine surgery, you must code Arthrodesis. So these instrumentations are coded with Arthrodesis. Next, you're going to need to determine the type of instrumentation. Is it segmental? The attachments are at the end of the repair area, and at least one other attachment is in the area being repaired. So you can see that this is a segmental because it has multiple attachments. Okay, this is segmental. Now, if it's not segmental, it's non-segmental, and the attachment of the devices at the ends of the area being repaired. So if you look at our device that we used in our reenactment, it is attached only at the ends of the area being repaired, the front end and the back end. Also, you're going to need to report modifier 51 for reinsertions, removals, or explorations. So that should tell you that these codes are not add-on codes. And finally, you need to know the approach, because these spine instrumentation or these instrumentation codes are coded and classified according to the approach. So that's a good thing. And here are your FTRs. Spine surgery must be coded with arthrodesis, segmental or non-segmental, approach, and report modifier 51 for reinsertion, removal, or explorations. Now, make sure that you document these FTRs on the pages of code series 22840 and 22859, because we are now moving on to learn about bone graft FTRs. Bone grafts or implant FTRs, code series 20900 through 20939. Bone grafts can be coded for any surgery, so these guidelines are general with the exception of FTR number 2. So the FTR is applied to almost any surgery except FTR number 2 and number 1 FTR. Code separately except if it's bundled in the code. So code bone grafts or harvesting separately unless the code language indicates that it's bundled in the code. Step or FTR number 2, spine surgery must be coded with arthrodesis or fusion. Just like instrumentation, you cannot code bone grafts for the spine surgery unless you have arthrodesis. And if you look at the code series, look at that 209, that's probably something you're going to see a lot, and you're going to realize that this is a bone graft procedure. And if you don't see it in a spine surgery, when there is, if you see this code and you don't see the arthrodesis code in a spine surgery, you know it's wrong. Next, do not report these bone grafts with modifier 62. A harvest of the bone graft is not of the same complexity as a spine procedure, so you don't need a co-surgeon for that, and do not append modifier 62 with bone grafts. Also, do not report do not report the bone graft add-on codes with modifier 51. So about half of the bone graft procedures are not add-on codes, and the other half are add-on codes. So just be aware of that, okay? And this is an image of bone grafting, just so you don't confuse stuff. We know the process, this entire process is arthrodesis. But the grafting material, that's the harvesting of the material that's going to be used to help fuse that part of the spine. And you can see it's a good image of it. Well, it's not the best, but it's one of the best that I've found. And don't forget, here are your FTRs that you need to document at the bottom of your bone grafts or implants codes separately, except if bundled in the code. For spine surgery, this must be coded with arthrodesis, and do not report with modifier 62. Do not report add-on codes with modifier 51. That's easy to do because there are a lot of add-on codes as well as a lot of non-add-on codes in this surgery. All right, so go ahead and document this FTR on your grafts or implants procedures pages, and I got a question for you. Are you ready to try coding spine procedures? Remember, only code what the doctor does and follow your guidelines. You are fine. And if there's any part of this spine surgery that you need to re-review, just press rewind. All right, coders, if you're ready to move on, I will see you on the other side. Time for our first coding exercise. Don't forget, coders, pause the presentation to solve. Are you ready, coders? All right, let's begin. A, 22612, 22614, 22842, and 20937. B, 22612, 22614 times 2, 22842, 20930. C, 22612, 22614, 22842, 2093, and D, 22612, 22614 with a 51 modifier, 22842 with a 51 modifier, and 20937 with a 51 modifier. The surgeon performed posterior arthrodesis of L4 through S1, utilizing morcellized allogenous iliac bone graft with pedicle screw fixation. I almost caught myself. All right, coders, pause the presentation to solve. If you said C, outstanding. All right, coders, so how did you solve your scenario? This is what I did. I always write down my instructions. Anytime I'm coding spine surgery, I need to do that because you could have several procedures. The first procedure that took place was arthrodesis. Second, instrumentation, then bone graft. Posterior arthrodesis, your pedicle screw fixation is your instrumentation, and your morcellized allogenous bone graft is your bone graft. All right, now let's take a look and see how I solved this scenario. All right, so here are our keywords. Posterior arthrodesis of L4 through S1. morcellized allogeneic bone graft, and pedicle screw fixation. And as you can see at the top, I put my plan at the top because I always need to make sure I know what I'm doing. At the bottom of the page, I didn't put the spine procedure FTRs, I put the Arthrodesis procedures FTRs because that's what's happening. All right, too, I have this green box around L4 through S1. This is the spine area that's being fused or having arthrodesis. So what I do is I go back down to my FTRs to determine the number of spaces that I'm coding. And if you look at the guideline below, it says the number of spaces determine the number of levels. So you're actually going to be coding levels. Levels and spaces are synonymous. So I'm a visual person and I need to kind of draw myself a little image. And as you can see, I didn't draw this image. I found this image of arthrodesis of L4 through S1. And remember, the number of spaces determine the number of levels that you're going to code. How many spaces are between L4 and S1? Well, if we take our little highlighter and just count 1, 2. So there are 2 levels between those vertebra or vertebrae. Okay, so now we know we're coding for 2, so we can begin. Okay, so I like this family, this parent code. It says Arthrodesis posterior. I like that language, but this code is for below C2. We need the lumbar. Yes, because we're going to start with where we start and we're going to end with S1. So we're going to code the first one, lumbar, and we know we're only coding 2 levels. So if you look at all 4 answers, all of them share 22612, so we know it's a good code. Now we know we have to code for the next level, and if you go below to the add-on code 22614, you code this for each additional vertebral segment. Okay, so we're going to use this add-on code, but wait a minute. If you look at B, it's coding 22614 times 2. So if it's coding that twice and also coding 22612 once, they're coding for 3 levels. So we know we just are coding for 2 levels and we have to get rid of B. Gotta go. Next, you know what I just thought about? This 22612 is a lumbar code, so 22614 must also be a lumbar code. So how do we code the sacrum? So, well, if I have a question, all I got to do is go to my parenthetical guideline. I got to go there first. It says use 22614 in conjunction with 600, 610, 612, 630, or 633. All right, so we can use it when performed at a different level. There you go. There is our guideline. It's telling us it doesn't really matter, just a different level. All right, so we are correct. And if you want to just look down at some more guidelines, here they are, but it tells us that this is a good thing. But I'm looking at D. Look at D. See 22614 with a 51 modifier. Should we put a 51 modifier next to this 22614? Well, absolutely not. It's an add-on code, and add-on codes are exempt from modifier 51. Therefore, you should not put add-on codes on, modifier 51 on add-on codes ever. It's just wrong. So we know the answer is wrong, and you know what? We can move on. We've already coded our Arthrodesis, so what do we do next? Well, if we look at our instructions, it says code your instrumentation. And if you look to the right, this green box 22842, it boxes the code because it's correct. We know it's correct because both A and C share that code. But let's take a look at why it's correct. This is the code for posterior segmental instrumentation, such as pedicle fixation. That is a key word that we found in our scenario, pedicle screw fixation. All right, so that confirms that we have the correct instrumentation code. Next up, the bone grafting. All right, so the difference between A and C are 20937 and 30. So if we go to the parent language of 20937, this is the code for an autograft. Coders, this is the wrong language because we need to code for an allograft, allogeneious, allograft. And you know what? 20937 is incorrect because this is the code for allograft for spine surgery, morselized. Wrong type of graft. And we need to code for the allograft, and it's below 20930. And I know we talked about the differences between an allograft and an autograft. Autograft comes from the patient. The patient is the donor. Allograft means it's the same species, such as a different person. So another person was the donor. So we know 20930 is an allograft, morselized. It is our correct answer. And coders, if you got that correct, outstanding. Now coders, are you ready for a little more challenge? All right, let's code some more spine surgery.
Thank you for watching an AMCI exclusive presentation in partnership with AAPC. Until next time.